from the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist Tony Stewart.
We are most pleased to bring you a 3-week series on the issue of physical therapy in order to accomplish our desire and task to inform you as much as we can of this subject. We have broken that 3-week series into 3 parts. On today's program, we are entitling it, What is Physical Therapy? And then next week we shall come back to you and we're going to talk about the surgery as it relates to arm injuries and what happens in both surgery and the physical therapy treatment. And our 3rd week is going to address knee injury and surgery and physical therapy. We will have both a physician and a physical therapy expert on the next 2 shows. Today we're very pleased to welcome to the program a physical therapist. Our guest is Rudolf Krebs. He is a native of the Netherlands. He was educated in that country. He went to and received his degree from the Academy of Physical Therapy in Amsterdam, the Netherlands. He then came to California, actually practiced in the Netherlands, and worked there, and then moved to Coeur d'Alene, Idaho, where he now practices. And I can testify to the fact from a number of people that he is an outstanding therapist. And Rudolf, it's a pleasure to have you on the program today, and we also are happy to have you back the next 2 weeks with Dr. John Geeson to take us through this very, very important issue, and we're very grateful. My first question to you has to do with, as I often ask people who are experts in the field, why did you choose this as an occupation? What drew you to the field of physical therapy?
That's always a difficult question. When you grow up, you you grow up in a certain environment, and an environment, of course, stimulates you to make a certain choice when you grow up. And in my case, my father was a research chemist for a large company in Amsterdam, Holland. And he was always interested in researching and finding new products and developing new products for this company. And so chemistry was kind of his specialty. And for some reason, I was always interested in the biochemistry of the body. And I always tried to I was always drawn to finding out why certain things were working and how these processes, these chemical processes were stimulated. And so because the body actually acts like a chemical plant, I got drawn into that and stimulated, of course, by my family. And that is how I became interested in the human body.
And as that interest grows, you just simply, in your education, you just get more and more involved, and then you choose that occupation. I've introduced the program today as What is Physical Therapy, and I know in our own country that in recent years physicians have used this more and more as a joint effort between the physician doing certain treatments or even surgery and then getting into physical therapy. And in the area where we live here, there's been just a real growth in that occupation and the number of physical therapists that are available in recent years. So what I'd like to do is start at the base and have you to talk to our viewers. Some have had an experience with this subject, some have not, and define for us what is physical therapy.
Well, physical therapy is actually the treatment of physical disability. That can be either a born disability, like a neurodevelopmental problem that occurred either before birth or after birth, and it needs special attention. So you can stimulate these people to get to their fullest potential, or it can it can be an acquired physical disability. For instance, when you swing a bat, you miss the ball, or you step in a pothole and twist your ankle, or you paint your house and you get shoulder pain.
Or an accident.
Or an accident, right.
Now, when you are receiving a patient from a physician and they've been referred to you, it depends on whether it is a physical disability at birth or whether it's an injury taking place with the type of treatments that you can give. I assume we'll get back into that in a moment. But of all the patients that you receive from this great spectrum of possibilities, would you share a little bit with us about, in some cases, can they be total recovery if it's a physical injury? In other cases, it may not be in your ability to completely get that individual to a complete normal physical process, but some improvement. That's a really involved question, but how could you explain to the viewers about the different types of recovery that would be possible?
Well, it depends, first of all, what the goals of the treatment are. The goals for a 75-year-old male who fractured his shoulder and seeks rehabilitation will be different from a 25-year-old male with the same problem, because the 75-year-old most of the time does not require the same functional abilities at the end of the treatment. The 75-year-old might, for instance, be very happy to get a certain functional range of motion where he can do his daily activities, whereas the 25-year-old would insist on, and I can't blame him, for having normal range of motion and normal strength and normal functional ability for a 25-year-old. So depending on the stress that the body still requires at a certain age, you have to either set the goals high or lower. And of course, it depends very much on what the patient himself wants. You cannot set goals for a patient that the patient really doesn't want to achieve. So communication between you and the patient is very essential.
And that will dictate even the kind of treatment that you may suggest.
And the outcome.
Or rehabilitation. In a few minutes we're going to do video, but I have another question first. One thing I've learned in my research and preparing for this program is that there are individuals, let's suppose that we're talking with injuries now, not something that one was born with, and a person is in an automobile accident or they're in a sport event and whatever that happens, and they really cannot recover, that they're having an arm problem or a knee problem or a back problem, and simply it's just not getting better on its own, and they go to their physician, and they may even be referred to an orthopedic surgeon. What I've learned from this process, and I would like you to take our viewers through it, is that in some cases what the physician will do, they will send the individual to a physical therapist believing that that treatment can prevent surgery. That's the first one. The second one is that when that doesn't work, then the individual goes and has surgery, which we'll talk about next week. And then following the surgery comes back to the physical therapist. So would you enlighten the audience a little bit about the positive aspects of trying to deal with this and maybe even prevent surgery?
Well, first of all, let's get into a, is it okay if I use an example?
Yes.
That makes it easier. A lot of times we're talking about soft tissue injury here, and that is either the muscles themselves or the tendons or the ligaments, but suppose it's a tendon. The first problem that you have to anticipate with is that a lot of times you cannot, it's very difficult to diagnose these specific tendon tears if they occur, which means that x-rays, for instance, won't reveal those tears. An MRI will sometimes, but it depends on whether the picture, who takes the picture, what the angle of the picture was. And so lots of times the physician will have to assume that it is an either partial or total tear. If there is a total tear, then surgery is, you cannot avoid. But if there's a partial tear, a lot of times with the good physical therapy, you can rehabilitate back to normal functional abilities. And that is the reason why the physician in many instances sends the patient to a physical therapist to see if you get that rehab potential without intervention of surgery. And that is where we come in.
And so in your treatment you find ways, which we'll get into next week, but you find ways that you're able to stimulate and have the tear to be healed and also get rid of scar tissue and all of that.
Yeah, so that depends. Depends how big the tear is, how bad it is. I'll give you an example. If a patient has a severe tear, you would just start an exercise program with that specific patient. A lot of times it doesn't get any better because you keep on irritating the same problem. You have to first stimulate the body to help it heal itself, to make sure that the adhesions are broken up after that, and then start a strengthening program to prevent a reoccurrence if possible.
And even if that doesn't work, it certainly was worth a try before surgery, because in many cases it does. The other question is that it's been a complete tear and there has been surgery, and then the patient comes to you, and again, next week we'll show an example of that. But does the treatment vary much? Of course, you have much more greater diagnosis because the surgery's been finished and the physician can tell you exactly what they've done. And then, how successful is the therapy to complete the recovery?
In most instances after the surgery, very successful, a very large and high recovery rate. The speed of the recovery depends on different different things. The experience of the therapist is number one, the age of the patient, the severity and the location of the tear, and the condition the patient was in prior to the tear. If the patient is in good shape, the tear took place and surgery took place, then rehabilitation will go much faster than in the instance where the patient was already deconditioned prior to the tear, and the tear has been repaired.
You have reminded me of something else in comparing these two patients. If someone comes to you and the physician indicates it's a partial tear and you're working on that, you're dealing with an injuries there. When the surgery, if it is particularly a younger person, the tear is completely gone. Therefore, the treatment between those two is quite significantly different, is it not?
Definitely, because after the surgery, you don't have to deal as much with the scar tissue issue anymore.
That's been removed in surgery.
Right. First of all, the two tissues have to be reconnected. It's done by surgery, and then it takes about 5 to 7 weeks before the blood supply between the torn tissue and the rest of the tissue, the muscle tissue, is completely restored to normal. And that means that during that time frame, that specific tissue continues to atrophy, becomes weaker. At the time that 7 weeks have passed, the patient pretty much feels good, because all the symptoms that come with surgery are at that time almost nothing anymore. And so, at that specific point in time, the patient is ready for a re-injury, because he is not aware of the fact that the tissues are still so weak. So the approach towards the patient is much more in the sense of letting the patient know what the chances are, what he has to deal with after the surgery, and so the recovery is much more focused on the exercise part, rehabilitation of the surrounding tissues, a change of lifestyle, what he can and cannot do. Again, because after about 7 weeks, the tissues are still so weak that it is very easy for a patient to forget that and do what he wants to do and tear it.
Now, one final question before we go to the videotape. You and I have discussed prior to this program that individuals, when they have injuries or back problems, sometimes they wish to go to a physical therapist, other times they go to a chiropractor for certain things. And I know viewers are often confused between these two approaches. Would you distinguish between what is physical therapy and the work that a chiropractor does?
Well, physical therapy is based upon modern medical facts and knowledge, modern neurophysiological, physiological, and anatomical views. And so physical therapy is a science. Chiropractic, I believe, is based upon a vision by a Mr. Palmer, who believed that the spine actually was built up out of a system of buckets, or represented a system of buckets full of energy. And from these buckets, the energy would flow to all the internal organs. And that is probably the reason why chiropractors believe that they can treat internal disease. Whether that is true or not is up to the viewer to decide, but the chiropractors are not medical practitioners in the sense of that they are medical doctors.
In the case of physical therapists, as yourself, you are receiving clients or patients that come from a referral from a physician. So you have, when you get the patient, some diagnosis already. Is that correct?
Yeah, we like to treat patients mainly that are referred from physicians, because you get a lot of background information from the physician. You get the diagnosis, you get his history, you get to know all kinds of specific things that might come up during the interview that you have with the patient that might warn you for possible precautions. And so it is very important to work together with the physician, because after all, you're both trying to help to get this patient back to his normal function, his normal daily activities. I don't see how you can do it any other way. You cannot do it on your own. You need to have that information. You cannot do without the skills and the knowledge of the physician.
Because you are dealing with a physical problem and you're trying to diagnose that and treat it.
Exactly.
I'm going to ask our crew to put some videotape up on the screen that they came to your place and did take. And on the very first part of the tape, I believe we're going to look at two kinds of treatments. One is electrical treatment, and then that's followed by ultrasound, and then we're going to go into something called rehabilitation and exercise. So I would ask them to give us this first tape, and then have you, Rudolph, to explain to us what you're doing in relation to this treatment. If we could have that videotape now.
Oh, this is a typical form of motor stimulation. It is an electrical stim treatment. The electrical stim can be used either for pain control. It can also be used to stimulate muscle tissue to contract. For instance, when a muscle is hypertone, doing so you decrease the tone in the muscle tissue and increase the blood flow. Well, this is an ultrasound treatment. Ultrasound being used as a modality to increase blood flow in the deeper tissues, especially the ligamental tissues, which absorb the ultrasound much better than any of the other tissues. And by doing so, of course, creating a situation in which the blood flow in those tissues increases significantly.
Here we've gone into your area of what we call rehabilitation. With your treatments, you're having rehabilitation. And take us through these different steps and processes.
Well, this is a typical warm-up session for this specific client. Before we start him on his rehabilitation program, we warm him up. It reduces the chance of injury. This is a session where we let the client go to knee extensions to increase the strength of the quadricep muscles of the upper leg. Actually, what you're looking at is a fairly far advanced client. This is way beyond normal rehab. You don't start at this level. This is the last level that you go to, last phase you go through in rehabilitation.
After you've had all the other earlier rehabilitation. And here's another.
Oh, this is a good example. Here you see my wife Janice, also a physical therapist, setting the motion limitator on a ham curl machine. This is a machine that lets you increase the strength of the hamstrings. Nice thing about this that it has a motion limitator which allows you to strengthen those clients within certain motion limits, so they cannot hurt themselves while they're on this specific equipment.
I've noticed a lot of your equipment does certain protections, other parts of the body while you're working on one particular one. Like some of the equipment protects the neck while you're working on something else, so it's not strained during the exercise.
Right.
In addition to, now this is also working on the, what portion of the body?
The leg.
The legs too.
The upper leg, yeah.
The upper leg, just like the other one was.
Yeah, this is
in
only
a
on the back
position.
side. The hamstrings in this case. You see that this time he's doing it unilaterally. You can do one leg at a time. It gives a much better fixation on what you're doing, so you cannot compensate too much. And depending on what level you are, you can either start you that way or reverse it, or change the training every time so you can never get used to the exercise. I
think another important footnote here is that you have a trainer there, and the patients, as they're going through this, they don't just decide on themselves. You've got very specific things you're doing.
That's right.
Such as in this video here.
Yeah, this is a typical, this is where you see we're strengthening the upper body, especially the shoulder area. I like to use this equipment because it gives them a variety of exercises that they can do that they wouldn't be able to do in another facility or at home. I like to train them in this situation because it is safe, and I know that they can't hurt themselves. We teach them actually how to do those specific exercises and do them in a safe manner. And so, by allowing them to work in this gym, in this typical gym setting, we are actually changing lifestyles. We are going beyond the physical therapy. We rehabilitate the patient, and then we teach him how he can carry on with his own rehabilitation.
And just like in here, you're doing another area of concern and rehabilitation, aren't you?
Yeah, this is again for the upper extremity, in this case the back. This is a typical exercise that you can do in almost any fitness center. The main thing is, though, that you teach him how to do it correctly, how not to cheat, how to get the maximum out of the exercise, and teach him to be responsible for his own continued success.
And then here we're doing, at this point,
this is a stair stepper. You can use this for, again, warm up or cool down, but you can also use it for a specific rehab, like for instance knee rehab, or general strengthening or general conditioning.
Well, I really thank you for having that video, because that really is visuals for the audience. It's very, very helpful. I want to talk a little bit more about rehabilitation. I am so interested in your theory, and all physical therapists, like everyone else, doesn't do exactly the identical form of treatment. I want to go back to, first of all, the ultrasound for a moment. I was so fascinated with your concept when there's an injury, and you locate on the shoulder, like the rotator cuff issue. You locate where the injury is, and would you explain just briefly to the viewers how you almost perform surgery yourself each treatment, something that you do before you put the ultrasound on the injury?
Well, it depends on the injury, of course. If you're talking about tendonitis, and one of the approaches that you can treat the tendonitis with is the typical the Cyriax method, developed by an orthopedic surgeon from London, England. It's an approach where the theory is this: once you have a tendon tear, a partial tear in the tendon will heal, and so you will get scar tissue in the tendon. But the scar tissue is not as good tissue as the original tendon tissue. It's not as flexible, and besides, the scar tissue also adheres to the surrounding tissues, the surrounding individual fibers of the tendon. When it does that, it affects you in the sense that when you contract the muscle or you stretch the tendon, you cause micro bleedings in those tissues, and that hurts. And typically, when that happens, a patient would feel, or a client would feel, that he feels an irritation in the shoulder at first, which then disappears, but comes back later. First, you break the adhesion, a micro bleeding sets in, and later, when the patient is not in that activity, that specific adhesion returns and causes additional problems in the shoulder. Now, what we do a lot of times is we break those adhesions with our fingers, called friction massage or friction mobilization. You do that, you break those adhesions, and then afterwards I like to use the ultrasound to increase the circulation in those structures so they can heal in a most normal way.
You're increasing blood flow and all with that treatment?
Yeah, but only on micro level.
Right.
Ultrasound in general does not increase blood flow in the sense that it will actually make the blood go faster through the arteries and veins. It actually increases the temperature of the tissue. And because it increases the temperature of the tissue, automatically an influx of blood will occur in those very small microvessels. And that increases, of course, and it speeds up the process of healing.
And so you do that for a while, treatments maybe 3 times a week, and as you get rid of that scar tissue and it starts to heal, after a certain number of those treatments, then what we saw on the video, then you move them into the exercise area
Yeah.
and start the rehabilitation.
Yeah, you have to wait until enough of those adhesions have been broken. You don't have to break them all. You have to break enough to make sure that the patient has full range of motion without any discomfort. And when that occurs, then it is the time to start the strengthening program. Would you start any sooner? A lot of times you'll discover that the exercises actually contribute to more discomfort. And so causing more inflammation in that specific area does not help. It actually counter-affects exactly what you're trying to accomplish.
But when you get to that point and they start slowly with their exercises and under your direction carefully start to build that strength back, and as time passes and that strength is there and they're basically, in some cases, depending on age and injury, they're back to normal, I want you to take us to the next step, because I know you believe, even taking it further, that even they thank you and they say, I feel healed and it seems normal again. You're very particular about not letting them go back to, in some cases, depending on their lifestyle, back to their lifestyle. Give us your theory about what they should continue to do once the injury has been taken care of.
It's not for everybody, but for most people who would like to continue recovering on their own and would like to become a little stronger to make sure that it won't happen again, I suggest, depending on what of course caused the problem, to continue that exercising independently. And especially here in North America, a lot of people like to go to fitness centers. It's a very popular subject. And the problem with fitness centers, though, is that they don't really instruct the people on how to exercise correctly. So I try to stimulate the patient in a sense that it is, if he has that kind of an injury caused by inactivity, he has some atrophy, take it one step further, and I give him an opportunity after the physical therapy program to continue on a 3-month program to learn how to exercise independently, in the sense that he could take that exercise program anywhere, to any facility he likes, and be able to independently continue rehabilitation on his own.
We're out now out of time, but I hear you saying too that not only do you want to strengthen that particular injury area, but you really expand to the whole body and try to get them to deal with the whole physical and emotional aspects of life, and I commend you for that. Rudolph, I have the signal that we're out of time, but on behalf of our staff, I thank you and would like to inform our viewers that you will be back for the next 2 weeks, and you'll be joined by Dr. John Geeson. And ladies and gentlemen, at that time we're going to deal with an arm surgery and injury, and also one with the knee, and I think you'll find those details very informative. And again, I would like to invite you to be with us for 2 more weeks on the issue of physical therapy. Until then, please have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Instructional Technology on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station. From the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist Tony Stewart.
Welcome to part 2 of our 3-week series entitled Surgery and Physical Therapy. For the viewers who were not with us last week, we discussed what is physical therapy with a physical therapist, and today and next week we're going to actually address 2 kinds of surgery and the physical therapy that is joining that particular surgery. Today we're going to talk about anterior cruciate ligament tear. For our laypersons, that has to do with a injury to the knee. It's a common injury that often requires surgery. And then next week we will discuss an arm injury or shoulder, and the kind of surgery would be involved with that. I'm so pleased to welcome to the program 2 experts that are highly qualified to discuss this issue today and again next week. I first welcome to the program Dr. John Geeson, who's a medical doctor and an orthopedic surgeon. Dr. Giesen, it's a pleasure to have you here this week and again next week. We admire you very much and look forward to your discussion of this particular type of surgery.
It's my pleasure.
And I'm very pleased to also welcome to the program Rudolph Krebs, who was with us last week, who is a physical therapist and will join Dr. Giesen in talking about the pre and the post physical therapy. John, if you would start out with us today to explain to us what you mean by this kind of injury, the anterior cruciate ligament tear, and take us through the diagnosis.
Well, first, Tony, I think we should describe a little of the anatomy and what is the anterior cruciate ligament. The anterior cruciate is a inelastic ligament or band that runs from the anterior tibia back, right here, from the anterior tibia back to the posterior femur. And that ligament then prevents anterior translation of the tibia on the femur. If it's torn, it would move forward like that. Now, just to describe a typical patient, will injure their knee in a cutting sport such as basketball, soccer, or...
If I can interject, if we can put up some photographs that you brought with you, then you can explain that as we proceed through. If our staff will put those up now.
That'd be great, Tony. The patient is injured in a cutting sport. The first picture shows the knee, and it shows the kneecap or patella with the patellar tendon, and on the side we have labeled the semitendinosus tendon, which is one of the hamstring muscles, and that tendon is important because we use those tendons for the repair. Again, I describe the patient that comes in with a swollen, painful knee from a cutting injury. Now, the most we have to go into diagnosis now because it's not easy to diagnose a torn anterior cruciate ligament.
If we can have the next photograph, that will explain that.
Well, because of the patient's pain, they won't let us get a real good exam. So we usually at this time have to either get an MRI scan, which is a magnetic resonance imaging. It's a computerized x-ray, if you will, which will show us if the anterior cruciate's torn. It will also show us many other things inside the knee. The other common injury in that kind of in those sports is a torn meniscus, and the MRI will distinguish between the anterior cruciate and the torn meniscus, or it can show us that both are torn. The other method used is arthroscopy. You can actually look directly with the arthroscope and see if the anterior cruciate is torn. Now, once I've seen the patient, I don't wait any longer as far as I send them right to the physical therapist, because physical therapy does several things. Number one, it lessens their pain so that I can evaluate the patient better next time. But it also keeps those muscles from atrophying so that if we have to operate, we have good muscles.
So let me interrupt and say, you're indicating by sending this patient to a physical therapist, it might prevent surgery, but even if you have to have surgery, you're in a better situation to perform that by this work with a physical therapist.
That's correct, Tony. Rudolph will speak a little more to that later, but even while I'm waiting for the MRI imaging to be done, or the scope, even if it's only a week, I think they should have physical therapy that week. Now, once the patient comes back and we have a definite diagnosis of an anterior cruciate ligament, then we have to decide whether we're going to do surgical treatment or non-surgical treatment. There's no definite answer. You leave it a lot up to the patient. But there are many people that if they modify their activities a little bit, they can do real well without a repair of an anterior cruciate ligament. They might have to give up basketball, but to a 40-year-old woman, maybe giving up basketball wouldn't be a big problem. Whereas if the patient is a 24-year-old basketball player or 22-year-old basketball player at NIC, they couldn't play basketball unless they have the surgery. So those factors enter in. Now, I'm going to let Rudolph discuss the non-surgical treatment with I'll just add one other thing. bracing is very important. There is a specific brace that will prevent that translation of the tibia on the femur. And even if I send the patient to therapy and I'm not going to operate, we often use that brace for even sometimes up to a year. Rudolph, do you want to?
Rudolph, you're going to tell us about what happens when the patient comes to you now for physical therapy, that they may or may not have surgery. You also brought along from, again, last week some video that they will show us. You explain, you have this diagnosis from the medical doctor, from the orthopedic surgeon. Tell us what you do that might prepare for surgery or even prevent surgery.
Well, a lot of times it depends, like Dr. Giesen said, very much on what the patient wants himself, and whether the patient is actually still involved in sports or can do without the extra stability that the ACL ligament gives in the knee. A lot of times the patient is sent to me to reduce the pain that he has at the present time, the swelling that he has from the injury, and to make sure that he keeps his normal range of motion. Also, what you need to address within physical therapy is the strength of the patient, because we're talking here with this specific injury only about stability. And what the physical therapy can do is the physical therapy can replace partially the passive stability that the ligament offers with active stability of the soft tissue, the muscle tissue in particular.
And so you're getting some video here of the kind of things that are done?
Yeah, this is a typical exercise pattern. You'll see that we'll use before surgery a lot of times to increase the strength of the quadriceps that create knee extension, and the hamstrings for the flexion. And this is typically done to increase functional stability, to replace that passive stability that's not there anymore.
Okay, and while all this is going on, you're also beginning yourself to diagnose whether or not this may be the cure that you're going to have without surgery, or whether this is a step back to the orthopedic surgeon for surgery.
Exactly. Depending on how well the patient does with this the typical form of exercising, the orthopedic surgeon and the patient together will decide whether this is the way to go or not. For some people who are very active, this will not do it.
Okay. So as we said last week, it has to depend on the age of the patient, what the patient's interests are, and what their activity will be in the future, what kind of advice that you give them and also the doctor. I know that you also do some other things in addition to the physical actual exercise, and we'll come back to that after we talk about surgery. But I think we need to go back to Dr. Giesen now and deal with the situation where, John, there's going to have to be surgery. And would you lead us through how that is performed and the complications to that process?
Yes, I will, Tony. If the decision is made to proceed with surgery, the first decision that has to be made is what kind of graft to use. Some years ago, we learned that you can't simply sew the anterior cruciate to itself. It's like sewing a paintbrush to a paintbrush. So we came up with different grafts that we put inside the knee in place of the anterior cruciate. Now, the two commonly used grafts, one is the one from the middle of the anterior cruciate, of the middle of the patellar tendon. We take bone from here off the patella, then we take tendon in the middle, and then we take bone from the tibia. Now, when you put that across the knee, the bone grows solidly to the bone, and you have a very rigid ligament. That surgery, however, takes a little more precision, and the other option gives you just a little more laxity as far as precision, is using the tendon on the side of the knee called the semitendinosus tendon. Now, we don't have one on this model, so if we could go to one of our pictures, I can show that semitendinosus tendon. But basically, the tendon runs from the hamstrings down to this side of the knee. Now, this picture shows how we drill holes to put the new tendon through, whether it be the patellar tendon or the semitendinosus tendon. Now, originally we opened the knee to do this surgery, but now we do all of this with the arthroscope.
Which is much more, I guess, less intrusion, isn't it?
Yes, with the arthroscope you only have one small incision down here and one over here. Now, there are three actually. You have to make a hole to put your tendon in, and you have to make a small incision if you're going to take your tendon here or here if it's a semitendinosus. Once you have the tendon and you've measured the length, you pull it through the knee, through this hole, up into the middle of the knee. It comes out right where the anterior cruciate attaches, right, I should use my pen, it'd be better, right there. And then we run it through a hole here that runs into the femur. We fix this rigidly with what we call interference screws, which are screws that go in alongside the bone. So when we're done, we can actually test the knee, and it's rigid. It won't move forward like that. So basically, in the immediate post-op period, we often put a polar pack or cold on the knee, and that helps with early pain control. And then they go right to physical therapy to Rudolph, and he can explain the rehab.
Before we go there, though, is when you do that kind of treatment to it, not only does it reduce pain, but does it also affect the swelling?
The polar pack?
Yes.
The cold? Yeah, absolutely. Yes, it decreases swelling and pain.
And one other question concerning, when I was talking to you earlier, when you're tying, you indicate to bone, you're creating a strength that it should really, if it has proper physical therapy, it should really be strong and not have complications in earlier surgery years ago before this technique was developed.
That's absolutely correct, Tony. In other words, the piece of bone that I put in this hole becomes one solid bone. It actually heals like a fracture would heal. So your end point, if you don't pull it out in the months when it's healing, is very strong.
Now we'll move back over to Rudolph, and Rudolph, you've got a very important communication with the doctor on what's happened. I'm sure you get a report on the surgery, and then the kinds of treatment. And you too have been kind enough to bring us some photographs and all. And would you take us through now what the kind of things that you'll do for this particular injury in the physical therapy?
I see that they put a picture on the screen here. This is to show one more time the connection between the ACL ligament and the PCL ligament and where they are attached. And if you look at the red arrow on the picture, then that is about where Dr. Giesen here drills his hole to reattach the semitendinosus or the patellar ligament. If you go to the next picture, then you'll see where it attaches, where he drills that hole on the femur.
If we can get the next picture up, then there we go.
There you go. That is where he attaches it on the other side. And this, of course, is seen from behind. And when we go into the rehab of an injury like that, then like Dr. Giesen said, he sends the patient home with a polar pack, which is a great invention because it reduces the swelling enormously, makes it much more comfortable for the patient to recover. In the past, we didn't have that option, and by the time that the patient would enter for physical therapy, they already had a lot of loss of motion and a lot of discomfort, and rehab is much harder. Like he said,
here's our next photograph.
These are typically the muscle groups that we are strengthening when the patient comes in with an ACL tear and a rehab. It shows the hamstrings. It also shows the muscles that are laying just under the knee joint.
So you're trying to get all that strength and before there's another injury.
Yeah, because these muscles work in groups. They're synergistic to each other. You cannot just work out one group and not do the other. That wouldn't make any sense. Okay. This is the gluteal area and the biceps femoris. Also, typically the gluteus maximus works over the hip joint, and the And the biceps femoris works over the hip joint as well as over the knee joint. And when you're rehabilitating those muscle groups to increase functional stability in the knee joint, you have to design specific exercises with a certain variation to increase that strength fast. That's why we're showing this picture. And these are the muscle groups on the front of the leg, also known as the quadriceps. And they increase, if you increase the strength of those muscles, then of course it creates a block. You have the hamstrings on the back of the leg, you have the quadriceps on the front of the leg, you're creating a stabilization of that knee joint.
And during this injury, all this has been weakened, and even if it may not be part of the injury?
Yeah, if the patient becomes inactive, atrophy sets in immediately, and you lose his strength quickly.
Can you take us further now with what you've done? I know this is over a number of weeks and months in the process. With this particular tear that we've been talking about, do different patients get different kinds of exercises depending on the extent of the surgery or the age of the patient?
Definitely. A typical athlete would need a much longer recovery than somebody who's not involved in athletics at all. For instance, somebody who would be a senior citizen, for instance, would be very happy to have normal function of daily living, where he has no deficit whatsoever with the activities that he's doing. But an athlete, if you do not rehabilitate him up to his maximum potential, his career might be over. So that's where the differences lay.
And even though he has a longer, or she, as an athlete, has a longer period of training and physical therapy than someone of another age or older or less active, but it is also correct, is it not, that you have more success with a younger person, that healing, even though it may be over a longer period of time to get the kind of strength you're talking about, healing goes faster when you're younger than when you're
correct.
older.
That's correct.
Okay. Take us then a little step further. As you're following the instructions of the physician, and I assume that the patient's going back to the physician and watching this progress, what else do you do other than certain kinds of physical exercises on the knee itself?
Well, the knee rehab process is in stages. One of the first stages would be to reduce the swelling and to increase the patient's range of motion. You give him all kinds of activities to do at home, and those specific exercises are designed for that purpose. Whenever the patient comes back to the clinic, it is only to increase the range of motion or to instruct the patient to increase that range of motion to what is really required for that patient at that specific point in time.
Now, how often do you see that patient while they're also following your instructions at home with certain kinds of exercise?
About 3 times a week, 2 to 3 times a week.
When you see that patient, are there some of the treatments that you're doing during that session, even before they go back home to follow the exercise?
Well, the patient rehabilitates as fast as he can, of course, because that's what we try to stimulate. And every time he comes in, we do a little bit more. And that means that you can reduce the typical electrical stimulators to reduce the pain and the activity on the heat and cold, but you increase the exercise treatment because you're trying to increase his endurance and his functional ability as fast as you can.
Take us quickly through, you talked about electrical stimulation, but you do other things like ultrasound. What kind of things do you put on the knee at each of those treatments?
Depends, quite frankly, that depends completely on how fast the patient recovers. I've seen patients come in the door who already have 90 degrees of flexion readily available, so I don't have to put a lot of emphasis at that time in pain control. Other patients come in and they have so much swelling in the knee joint that they won't allow you to move their leg or help them move their leg. And therefore you have to put more emphasis at pain control and swelling reducement at that specific time. So it really changes with the patient.
Rudolph, I need to pause for just a moment to tell our viewers that Dr. Geeson had to leave. He had an emergency surgery, and that happens in the medical field, and you and I will continue this program together, and he'll be back with us again next week. Before I was interrupted with that announcement, you and I were talking about exercises, and I want to ask, is there just one type of exercise that is used in this kind of rehabilitation of the knee, or are there different types and sets of exercises?
Well, actually, you follow a certain protocol. We call it the knee rehab protocol. And within that protocol, there's all different type of exercises depending on the level that the patient is when he enters the program. Typically, the program will be built up out of open chain and closed chain exercises. Open chain exercises are exercises where the extremity is actually hanging in the air. That's the easiest way to explain it. Whereas closed chain exercises in this case would be exercises where the patient is actually standing on the floor with both feet. That would be a closed chain. Now, open chain exercises are the typical exercises that patients start with when they start rehabilitation. A form is, for instance, isometric contractions. The leg itself lays on the bench, and you ask the patient to make contractions in the muscle tissue, either the hamstrings or, in this case, the quadriceps.
Without the pressure of standing on it.
Right, exactly. There's no actual pressure on the joint itself, which is an advantage in that case, and it is much easier for the patient to do those specific exercises than anything else. It's also much safer, and you would go from those isometric exercises to exercises where you actually get concentric contraction. Now, isometric contraction would be where the origin and the insertion of the muscle do not change. I can give you an example. If you use the arm, if the arm would be in this position, then by making a contraction, the arm actually does not change position. That is a typical isometric contraction. And a concentric contraction is where the origin and the insertion of the muscle get nearer to each other. In this case, it would be the bending of the arm. So you go from isometric contractions to these specific concentric contractions in a very gradual process. And by doing so, and this is all open chain exercises, of course, by doing so, you can increase weight at a certain point in time, depending on how far he is how far this patient would be in the rehabilitation process, or you can add resistance. You could, for instance, give resistance under the foot by pushing against the heel of the foot. The muscles, you ask a certain contraction of the muscles that you automatically would do. It's like almost like yourself pushing away from an object.
Because of time, could you quickly tell us what the opposite of that would be, or actually when they're standing on the...
Well, from that point on, you can do some crutch training where the patient would be go from partial weight bearing to full weight bearing, and after that you would automatically go to the closed chain exercises. An example would be, for instance, where a patient would be leaning against the wall with his back, and he would make knee bends or squats, pushing himself up and down against the wall, sliding up and down. Typical, very functional exercise. And from there on, you can go on to exercises like balancing, where you put the patient in a situation that the knee is more unstable, and then you test and train the stability of the knee. You can also go to basic training at that point in time, where you can let the patient make certain steps, small steps at first and larger steps later on, to change the position or to change the stress on the different muscle groups. And then, of course, going from larger steps to faster, building in speed, going even to sprint training. And after that, it's all advanced conditioning and strengthening. The advantage or the difference between the open and the closed chain exercises actually is that in the open chain, it's much easier to put stress and to train a specific muscle in the group. Because by slightly changing the position that the leg is in, you actually change the specific muscles that you're training. And if you are in a closed chain position, you always put emphasis on all the muscles in the group. The whole group acts like a very strong contraction.
That's really a major difference, and it's
Right.
still a process in progress. Again, short on time, but once all of this has happened and we've gone through all of these steps, how long is the rehabilitation program? And I know it may vary depending on the patient and age and so forth, but approximately what is the time we're talking about in rehabilitation?
Typically 4 to 6 months is normal. It depends a little bit on the patient again. If you're talking about a young 17-year-old kid that needs to be able to play basketball or baseball, then you would go the full 6 months, because in those specific sports, the sudden stops that are required to do the ball games cause an enormous amount of stress on the ACL ligaments. And you have to make absolutely certain that at the time you release them, they can do those sports without any hindrance. A middle-aged patient who would be working behind the desk mainly could be released sooner. He would still have to continue his strengthening training, but he could do that at a much slower pace.
So in closing out the program, we are indicating that there's different exercises and different times for different people, and of course, through all that, you increase the chances of not re-injuring it. With that, I have to close our program. Rudolph Krebs, thank you, and I want to thank Dr. Giesen, who was on here earlier today with us. And ladies and gentlemen, I would like to invite you to be with us next week when we will do part 3 of this series. At that time, we're going to do a discussion of surgery and physical therapy on the shoulder, a rotator cuff problem, and I think you will find that most informative. We will do both discussion of the surgery and the rehabilitation. Until then, please have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Instructional Technology on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station. From the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist, Tony Stewart.
I am most pleased to welcome you to our third part of a series entitled Surgery and Physical Therapy. With today's program, we will bring to a conclusion this 3-week series, and we've been very fortunate to have 2 experts during this series that really know what they are dealing with. I would like to tell our viewers, too, that today our subtopic is the rotator cuff or the shoulder, and we're going to talk about a rotator cuff injury and how one deals with that in physical therapy, surgery, and then physical therapy again. I am so pleased to welcome to our program once again Dr. John Giesen, who is a medical doctor with offices in Coeur d'Alene, Idaho. He is an orthopedic surgeon. Dr. Giesen, I welcome you back, and you've been most informative, and we're delighted that you're going to assist us again in helping our viewers understand this particular problem that many people have. Welcome back to the program.
Thanks, Tony.
And I'm also equally pleased to welcome back Rudolph Krebs, who's a physical therapist with offices in Coeur d'Alene and Hayden Lake, Idaho. And Rudolph, it's a pleasure to have you back to work with Dr. Giesen and talk about how we deal and bring together surgery and physical therapy.
You're welcome.
Dr. Giesen, I'd like to start with you again today, please. We have some pictures that we're going to use, and you have a model with you. And before we do show those, I would first like to thank Gail Hughes and Lindy Turner, who are on our staff and did a really remarkable job taking your visuals and making them so clear for our viewers. Let's start with what is the rotator cuff, and I think we're going to start with a picture and that you can describe that for us.
All right, Tony. Well, the rotator cuff in its simplest sense is a tendon that lifts the arm. On the picture you can see the tendon with a rotator cuff tear, and that shows how the tendon goes under another bone, which we'll mention later, called the acromion. But why the term rotator cuff? Well, if I could use this model, the rotator cuff is a conjoined tendon. Several muscles come together in a tendon to attach on the humerus, or right here. And when these muscles contract simultaneously, it lifts the shoulder straight up. But if we were to name these muscles, the one in the front here is called the subscapularis. On the back, we can't see them really on the model, but there's two muscles on the back. When the person selectively has the anterior muscle contract, the humerus will internally rotate while it comes up. But if the posterior muscles off the scapula or shoulder blade, as we might call it, if they contract, the shoulder will externally rotate. So that's why we call it the rotator cuff. Now, maybe I should just describe a typical patient that comes in with a rotator cuff tear. The patient is often a middle-aged or elderly person who lifts something, often not a very heavy object, and they'll feel a pop. And after that, they'll have pain in their shoulder, and they'll have difficulty lifting their arms, sometimes frank weakness. Now,
could I interrupt just to ask
surely.
you, depending on the kind of injury it is, the way they lift it, the pain could be different. In other words, all injuries are not identical in the rotator cuff. In other words, in some cases, it may be more difficult raising it up, or other times moving it backwards.
That's true. With a rotator cuff tear, the weakness is in the lifting it straight up. That's where the problem is. But that brings up the point that I was leading to. There are several other diagnoses that are often confused with the rotator cuff, and you can't tell for sure. And the common one is simple tendinitis. That'd be inflammation of this tendon, the rotator cuff. And the other word you've heard doctors use over the years is bursitis. Well, bursitis is just a sac that you can't see here. It isn't on this model. It's a sac that's is a cushion, if you will, and a pad, and that gets inflamed. So we've often used that term. But as you can see, and the third term, excuse me, is the impingement syndrome, where the tendon presses against this bone. It's the only tendon that goes under another bone. So anything that causes the tendon to swell, or as such as a tear or just inflammation, will cause that tendon to pinch when you lift up. So the impingement syndrome classically is more pain when you reach out, whereas the tendinitis is more of a constant pain and often aggravated when you reach behind your back, like you mentioned that earlier. And there's another tendon here, the biceps tendon, that comes up right here, and that often gets inflamed. But as you can see, this is all part of the same process. And that's why it often doesn't take a very severe injury to rupture the rotator cuff. The rotator cuff is first gone through a process of many times of many periods of inflammation, and then it has you've had impingement syndromes where the tendon coming up rubs on the acromion, and so the tendon is ready to rupture, if you will, when the relatively minor injury comes along and it ruptures. Now, as I said, when the patient comes into my office complaining of shoulder pain, I don't have a specific diagnosis right away. Often the plain x-rays will be normal. So the first thing I do is send the patient to physical therapy. Many times that'll totally correct the problem, especially if it's a tendinitis, but it'll also help me with diagnosis. So now I'll refer the subject to Rudolph.
So as we go over to Rudolph, you're saying that you may not have a complete diagnosis, and the physical therapist will help you with that based on the kind of treatment that that person is conducting.
That's right, Tony.
Rudolph, we know that in numbers of cases that surgery is not needed because of the fact that good doctors like Dr. Geeson will send them and try this first. Would you take us through what happens when that patient comes to you with the amount of information you do have from the doctor, as much diagnosis as possible? And again, our staff has prepared for you some excellent pictures that you will take us through as you do this.
Let me first, before we start with the pictures.
Okay, we'll go with those pictures and we'll come back to what you want to say.
Okay, now this is a typical, just to give you an idea what a tendon is and what a muscle is. Where the circled part is typically the tendon part. That is what we're discussing at this time, not the muscular part. We can go to the next picture. In form of tendinitis, where you have a partial tear of the tendon, a picture would typically look somewhat like this, where some of the fibers are intact and other fibers are torn.
Not torn all the way through.
Not torn all the way through. Very difficult to diagnose unless you do some, the doctor goes into extensive exploratory or use of MRI equipment. And because a lot of those problems do not require that right away, most physicians will go to physical therapy first because it is less expensive than going to the great cost of those specific diagnostic procedures.
Now if we can go to the next picture, we'll take it the next step.
When a tear occurs, the body normally heals itself, and so it does that with scar tissue.
And we're seeing scar tissue here.
That is the tissue that looks like the spider web formation on the inside of that gap. You also can see in this picture typically that scar tissue also has the tendency to adhere to the surrounding tendon fibers.
And it just won't go away. It'll just heal and stay there, the scar tissue.
That's right.
Without treatment.
But in any event, it always, scar tissue is a necessity. The body restores itself with scar tissue.
But you're still having problems.
If you leave it untreated, yes.
The next picture there.
This shows the total recovery of the tendon, the repair by the body itself. Most of the time you'll see that the tendon is a little thicker, like John just explained. That is because scar tissue does not discriminate. It grows in randomly, it fills up the gap, it tries to restore the body into its original condition. You can still see in this picture though the adhesions that are surrounding the scar tissue, and these adhesions adhere to the individual tendon fibers.
Not only are you continuing to have pain, but also within this weakened condition, when you not also be in a situation of even having greater injuries without it being repaired?
Sorry again?
I'm just saying, could you not have also greater injuries by not getting this taken care of, even if you live with the pain?
It depends on how big the tear is. If it is a large tear, yes, but if the tear is minor, sometimes people don't even know they have a tear.
Would you take us through the next series of pictures we have now in relation to the problem?
Sure. This is typically the insertion of the rotator cuff, where you can see the supraspinatus tendon being inserted onto the bone. You can also see the acromion that is laying just above the tendon. And if we go to the next picture, you can see what happens when the muscle contracts. At this point in time, you can see that the head of the humerus is slightly elevated, and the tendon and the acromion are nearing each other. They're getting closer together. This is a typical situation where when the shoulder is elevated and the arm is lifted up in this position, that is typically when the pain occurs if there is an impingement syndrome present.
And the final picture we have.
At this point in time, the arm has been lifted over beyond 90 to 100 degrees, and in that situation, the pain typically disappears again because if there's an impingement syndrome present, because at that time the compression does not take place between the tendon itself and the acromion. And so what we just looked at is a typical painful arc. Patient can partially lift the arm, there's no pain. Patient lifts the arm a little higher, there's a pain present, and when he lifts it higher up again, the pain disappears. Mm-hmm. And that's what we call a painful arc.
Now that you've done such a good job with our viewers telling them what it looks like and what it is, what else do you do before you send the patient back to the physician, or in some cases maybe they don't go back to the physician that's taken care of?
Well, first we evaluate the patient to see what the goals need to be in physical therapy. Sometimes we can treat those patients and further intervention will not be necessary, and sometimes it won't. In any event, we always find those painful arcs, and that shows actually either a tendonitis or an impingement syndrome. We try to treat that by using friction massage. The pictures that we just looked at typically show the scar tissue that is present, and what we try to do is we try to break the adhesions that are present between the scar tissue itself and the tendon tissue.
Now, you talked about that bedding massage. Tell us exactly how you do that.
Well, it's called cross-friction massage. You actually put your finger or your thumb on that specific tendon, and you break those adhesions by making a cross pressure over the tendon.
So you know exactly where that is in the shoulder, and you take your thumb in there and you break that up, and then after you do that, what's next in the treatment?
Well, once these adhesions have been broken, I like to use ultrasound to increase the temperature of the tendon tissue, to increase blood flow in the tendon, and to let the tendon restore in a most normal situation.
And then after the ultrasound, you ice it for a period of time?
That's right.
Now, for our viewers, that's not just one visit that does that. This is a repetitive thing that you do over a number of weeks, is it?
Yeah, normally that takes about 6 to 10 weeks before you have a fairly good restoration. But sometimes there's no recovery at all, and then after about 6 treatments or so, I refer the patient back to the physician.
Then we'll go back now to Dr. Geeson, and John, if you'll take us. Rudolph has tried. In this case, has not been successful. Now it's going to be surgery, is it not?
Well, it's time, Tony, for more diagnostic tests at any rate, and not necessarily surgery, but there are basically two tests we can do. One is called the MRI, or magnetic resonance imaging. It's a computerized imaging exam, which is very good at diagnosing the shoulder. It will show us tendonitis. It'll show us a rotator cuff tear. It gives us some idea of an impingement syndrome. The other way to diagnose the shoulder is arthroscopy, where we put a arthroscope inside the shoulder and look in the shoulder. Now, the advantage of the arthroscopy over the MRI is that with arthroscopy we can fix some things when we're there. So we make a judgment which method is better, and we go ahead and do one or the other. Now, if we find a complete rotator cuff tear, then we do proceed to surgery. But if we find a partial rotator cuff tear, we will often we call it debriding. We'll cut the edges of the tear and to try to bring blood back into that area, to make it bleed and make it heal, and then we'll send the patient back to Rudolph. And I presume if it's an incomplete tear, Rudolph, you know many of these will heal, and you proceed with therapy again. But then, of course, sometimes an incomplete tear will not heal with physical therapy, and sometimes they come back. But if we do make the decision to proceed with surgery, and the patient agrees that that's the most reasonable plan, then the surgery is typically arthroscopy first, where we look within the shoulder and diagnose the problem better, and then we make a short incision. I do to do a rotator cuff repair. We make a short incision right across here. It's not very long, and we split the deltoid muscle, which is a big muscle that covers right over the top of the shoulder, and we get to the tear in the rotator cuff right here. Now, one of the things that has changed our success in surgery is someone came up with the idea of a suture anchor. Right, it tears right off here, and they came up with this anchor. You screw a little screw into the humerus, and it has suture threads coming out of it, and then we pull the tendon down and suture this tendon to that solid anchor, and that's really helped the results. The other thing that we often do, remember how Rudolph explained that the tendon, even when it heals, is larger. Well, when you do a surgical repair and put sutures in there, you know it's going to be larger, so we're going to have trouble getting it under that bone again, the acromion. Again, I'll show this bone. Yeah, I got to show it this way, the acromion, and that has to go under that. So we often do what we call an acromioplasty. We cut off part of this bone. Now, in the case I described, I do it open with a small incision, and it can also be done arthroscopically, which is another option. So we proceed with the rotator cuff tear. We often keep the patient in the hospital overnight because it's kind of a painful surgery, and then right away send them back to physical therapy for rehabilitation.
Now, before we go back to the physical therapy, by cutting off a section of the bone there, you're making it possible when you lift the shoulder that corrected surgery can move. It's larger because of that scar tissue, but it can move under the bone without
that's exactly
rubbing
right.
against the bone.
All we're doing, we just take a very small part of the bone off, and of course, I suppose the question is, well, what's that bone for? You know,
Yes.
Well, the deltoid muscle attaches there, so we do. I suppose theoretically we weaken the deltoid attachment a little bit, but it doesn't seem to be a problem, and it gives that tendon more room and relieves pain that way.
You're really speaking to a layperson that knows nothing really about the medical process, but also by talking about using that screw where you are actually fitting into the solid area of bone. Then you have strengthened that whole process to where there's less likely of it tearing again, or unless there's some other major injury.
It really is very effective. I think the one problem I should mention, and it's a good time to mention it, especially in elderly people, sometimes the tear is so large and it's been there so long that you cannot pull it together. You cannot repair it. And then the best we can do is roughen the edges like we talked about before with the arthroscope to get new blood into the area and allow it to heal, but they do not do very well. But if you can get a solid anchor in the bone, the repair does not usually re-tear. It's pretty effective and pretty solid.
On the elderly people, when you talk about when you're not able to perform that surgical procedure the way you wish to, then they will always have a weakened shoulder or will have problems with it?
That's correct. They'll always have a weakened shoulder, and that's why we are more aggressive now than we were, say, 5 years ago in diagnosing rotator cuff tears, because we don't want the tears to get so large we can't repair them.
So again, I'm always concerned about the viewers and helping them in every way we can. So if one is beginning to have if one has an injury, for example, and one's having problems with their shoulder, like we talked about last week with the knee, it really pays to have it addressed at once, does it not?
Yes, it does, Tony. And in truth, I can think of quite a few elderly patients that we couldn't repair. Hopefully, in the future, they won't get to that stage.
Yeah. So, it's like other issues, it's good to check out the problem that you're having.
Yes, it is.
We'll go back to Rudolph. And Rudolph, now the patient's had the surgery that Dr. Geeson has just explained, and patient's back to you for treatment. Now that we've had, let's take a case where it's been successful surgery that he described, and what happens next?
Well, there's actually two parts, of course. There's, first of all, if the tear is total, in the beginning, whether the tear is total or partial, the care is pretty much the same. The patient comes in still with a lot of pain, most of the time arm in a sling. The first thing that you want to make sure of is that the patient remains his normal range of motion. The longer he keeps that arm in the sling, the more passive he gets, the more chances there are that he will lose normal range of motion. So the physical therapist is there to help the patient to go through what we call passive exercises, where the physical therapist helps to maintain the patient's full range of motion. And by doing so, there can also not be any compression from the soft tissues under the acromion. Another aspect is the pain control. The patient comes in with a lot of discomfort. He doesn't want to really use the shoulder, but he hikes it up. It's a very natural reaction because it's a protective reaction. But by doing so, of course, he pushes those tissues against each other. It irritates it on a regular basis over the length of the day, and that's also not very good. So we do something about the pain control, so he drops his shoulder back to normal. And we do something about the swelling. You do that both when the tear is total and when the tear is partial. After that, if there's a total tear, the recovery time takes much longer because it takes much longer to go through all these different steps of rehabilitation.
Last week, for our viewers who weren't here, we talked about something like 4 to 6 months for recovery.
But that's typically for an ACL ligament in the knee. With this, it depends a little bit. It depends on whether this is a partial tear or a total tear.
It'll be longer if it's total tear.
And how old the patient is. The age of the patient is in this case very significant, and whether the tear was discovered early on or later.
Okay, we're running a little bit short on time, so let's go into some of the actual treatments now that you have a diagnosis of a partial or total tear.
Okay, after the passive stage, we go into the active assisted stage. You teach the patient how to use his extremity, his good side to help the bad side. I'll give you an example. Whether we let the patient at that point in time help to go to forward flexion by letting some of the weight come off the other arm, so you lift actually with one arm up the other one.
So there's some actual physical exercises that you're guiding that patient through.
You can only do that when the pain has decreased, but you try to do that, of course, as is tolerated, and that is why you're having a constant you have a constant conversation with the attending physician, because you need to know whether it is allowed at that specific point in time to do so.
And while you're doing those very limited exercises, are you also doing other things like ultrasound and all during this time period too?
It depends.
On the type of patient?
Yeah. Sometimes you do. It depends on the scar tissue. There's a lot of scar tissue. If there's a scar tissue a scar on the shoulder that is immobile, you can use the ultrasound to make it more mobile. Just part of the treatment.
You have some other pictures you're going to show us. I'd like to do those now if that fits into where you're at in your treatment, so that our viewers get to see that during this show too.
Yeah, typically, go ahead. This shows the combination deltoid muscle and also the rotator cuff, in this case the supraspinatus. I'm showing those because in rehab it's very important to work with both of those two muscles, because if you place the shoulder in a certain position, then the deltoid muscle takes over the activity that the supraspinatus normally would have. I give you an example. If the arm is close to the body, most activity that will be developed when you're lifting up the arm to the side will be done by the supraspinatus muscle. But once the arm is in a 60-degree, what we call a sideways motion, the deltoid muscle takes over most of that activity. And so when you start exercising those patients, you let the deltoid muscle do most of the work, because you do not want to put a lot of stress on the muscle that is recovering from the surgery.
And there are real techniques to cause that to happen. The next picture, we'll look at this.
That is the deltoid muscle that is laid open, cut open, and then you typically can see the rotator cuff laying right underneath. You can see when you look at the location of those two muscles that if you place the arm in a certain position, the deltoid muscle typically can take over that specific action.
And the final picture that we have.
There's the rotator cuff, the supraspinatus in particular, and you can see the deltoid laying right over that.
We have 2 minutes left, or a little under 2 minutes now. And so, Rudolph, now that you've gone through and you've protected the injured part, and as it's strengthening, what do you do next?
You put more emphasis on the part that was injured to begin with, and you go from active assisted exercises to active exercises, and after that going to resistive exercises and advanced strengthening.
And when all of that has happened, and the surgery's been successful, the person, John, is back to hopefully normal, to where they can, depending on age and type of injury, they can return to their normal activity.
Well, they're able to serve that tennis ball, Tony, if that's important.
For our viewers, knowing that John Geese and I both like tennis, and that's why we discussed that. With that, I have to bring the program conclusion. On behalf of our staff, I want to thank Dr. John Geese and Rudolph Krebs for 3 very informative weeks, and we appreciate all the time you've taken. Ladies and gentlemen, I hope you've enjoyed this series as much as we have in bringing it to you, and it's been informative to you. And I'd like to invite you to be with us again next week at this same time, when we will move to a different subject. Until then, please have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Instructional Technology on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station.